Good morning, students. This morning I will be talking about water and electrolyte metabolism. According to the MCI curriculum, the competency addressed in this lecture is part of BI 6.7, where I will be covering water and electrolyte balance of body fluids and the derangements associated with these. The learning objective of this lecture are as following. At the end of the learning session, the student will be able to understand the distribution of water in the body, describe osmolality of ECF, describe electrolyte composition of ECF and ICF, and explain regulation of water and electrolyte balance. As you can imagine, water is the most important constituent of. I will break the topic into three parts. First, we will study the distribution and composition of body fluids in various compartments. Then we will see how the water balance is regulated, and next we will look at some of the disorders of water metabolism. Let's first look at the distribution of body fluids. Before moving forward, let's first have a look at some definitions. Body fluid. Body fluid refers to all the fluids or liquids present in the body. Next is total body water. These are all the fluids present in the body except that in the GIT and urinary tract. What is lean body mass? Now, it is the body mass excluding the amount of fat. That is, it is about 85% of total body weight in males and about 70 to 85% of the total body weight in females. So that means females have a little bit more body fat than males. Water is the most abundant constituent of the body. Water comprises various percentage of body weight in different situations. Now this slide shows the water as percentage of body weight in different individual. It is about 60% in young healthy adult male, about 50% in young healthy adult female, approximately 40% in middle age adult female, about 45% in age adult female, and about over 70% in an infant. Now let's look at the various body fluid compartments. Body fluid is divided into extracellular fluid and intracellular fluid, which is all the fluid present inside the cells. Now the extracellular fluid is further divided into blood plasma and the interstitial fluid, which is extravascular and bathes the cell. The extracellular fluid is ECF is approximately 25 to 45%, and the intracellular fluid is 55 to 75% of the total body water. This slide shows body fluid fractions of total body water. Extracellular fluid is 1/3 and intracellular fluid is 2/3 of total body water. Further, extracellular fluid is divided in the ratio of 1/3 into plasma and interstitial fluid. Let's take an example of a 70 kilogram male and calculate these volumes. The total body water, which is usually 60% of the body weight, will be around 42 liters, and the intercellular fluid will be around 55 to 75% and will come out around 28 liters, and the extracellular fluid will be 24 to 45% and will be turned out to be 14 liters. And if we go ahead further and break down the ECF volumes, the plasma will be around 3.5 liters and the interstitial fluid will be 10.5 liters, which are in the ratio of 1:3. This slide summarizes all the volume calculations as we did in previous slide for a 70 kilogram male. Let's look at the definition of osmolality. This is the solute or particle concentration of a fluid and is expressed as its osmolality, and the units are milliosmomol per kilogram. It is very important to note that water crosses cell membranes to achieve osmotic equilibrium, with the aim that ECF osmolality eventually is equal to ICF osmolality. Now let's see the composition of body fluids. Like any other solution, body fluids have solutes present in solvent, which is water. They are not true solutions but colloidal in nature. The colloidal solutions are not true solutions. They are heterogeneous solutions having two clear parts or phases: the dispersed phase made of solute particles and the dispersion phase consisting of the solvent. The solutes present in the body fluids are of three types. Number one, electrolytes, which are sodium, potassium, calcium, magnesium, chloride, bicarbonate, and phosphate. These are the major ones. Next, there are small organic diffusible molecules such as glucose, amino acid, fatty acid, urea, etc. And number three, there are large non-diffusible molecules such as proteins, lipid, glycoprotein, etc. Let's look at the ionic composition of the plasma in determining the. Now, solutes that are restricted to the ECF or the ICF determine the effective osmolality of that compartment. Total body sodium is content is a reflection of the ECF volume. So as stated before, potassium and its anion are limited to ICF. Their number is constant. So any change in ICF osmolality is mainly due to change in the ICF water content. Let's learn the clinical significance of these concepts. In chronic hyponatremia, for example, when the sodium concentration is low in the ECF, the water will tend to move inside cells to balance the ECF and ICF osmolality. Brain cells can lose the intracellular solutes in order to defend against large water shifts in the ICF, and this process is called osmotic adaptation, so helping in maintaining the neuron cell volume. The process is mediated initially by transcellular shifts of potassium and sodium, followed by synthesis, import, export of organic solutes such as inositol, betaine, and glutamine. The opposite happens during chronic hypernatremia. This slide shows the osmotic composition of plasma. Plasma osmotic osmolality ranges between 275 to 290 milliosmomol per kilogram. Also note that the urea acts as an ineffective osmomole as it freely crosses the cell membranes and does not contribute to water shift across compartments. Let us now examine how fluid exchange works between various compartments. Now, water moves freely between the various body fluid compartments. Two forces which determine these movements are: number one, hydrostatic pressure. This is the pressure which is generated by the pumping action of the heart. And the second is the osmotic pressure, which is due to the virtue of plasma proteins. Fluid movements between intravascular and interstitial space is governed by Starling law. This states that fluid moves in the direction of the sum total of the forces on each side of a membrane. The net driving pressure can be easily calculated from the equation above, which is guided by the hydrostatic and osmotic pressure on each side of the membrane. For example, if we plug in some numbers here, we can see that the net filtration pressure is around 13 millimeter of mercury. It is interesting to note that at the arterial end there is comparatively less oncotic pressure and high hydrostatic pressure, whereas at the venous end it is opposite. So the lymphatic fluid comes from the arterial end in the interstitial space and gets back to the venous vascular compartment at the venous end. Around 2 to 3 liters of lymphatic fluid is produced per day. It helps to return protein present in the interstitial fluid back to the circulation for metabolism. If there is a problem in the drainage of the lymphatic duct fluid, then accumulation of fluid can happen in the interstitium, and this may lead to edema. Now let's look at the water balance. Osmotic composition of plasma. The main aim is to maintain the plasma osmolality in the range of 275 to 290 milliosmol per kilogram. Now, this is kept within a narrow range by mechanisms which sense a 1 to 2% change in the tonicity. And to be in balance, water intake should be equal to water excretion. Let's look at some of the water intake sources, which is usually 2 to 3 liters per day. The water intake sources are dietary fluids and water, solid food water, which comprises around approximately 800 to 1000 ml per day from cereals, vegetables, food which we eat. Next is the metabolic water. Now this is produced during metabolism, and it accounts for approximately 200 to 300 ml per day. The primary stimulus for water intake is thirst. This is mediated by the increase in blood osmolality, that is approximately 295 milliosmol per kilogram, or decrease in blood volume or pressure. Osmoreceptors in the hypothalamus will sense this change and stimulate the thirst centers in the hypothalamus, leading to thirst and leading to water intake, and finally decrease in blood osmolality. Similarly, decrease in blood pressure will increase the angiotensin II release, which will also stimulate thirst centers and lead to water intake. Please note that normally daily water intake exceeds physiological requirements. Obligatory water loss. Water is excreted via the following routes. Number 1, evaporation from skin and respiratory tract. Now this is insensible loss via skin and respiratory tract, 700 to 800 ml per day at normal temperatures. Number 2, sweating. Now this is the visible loss of water from skin up to 3 liters per day, rises with physical activity level and temperature. Number 3, loss via kidneys, so a minimum of 600 milliosmol per day must be excreted. Maximum urine osmolality is 1200 milliosmol per kilogram. So therefore the urinary water loss of 1000 to 1500 ml per day, of which 500 ml per day is obligatory and the rest is facultative loss. Loss through GIT up to 100 to 200 ml per day. This is a minor component except in diarrhea and vomiting. Let's look at the regulation of water excretion. Water excretion is tightly regulated. It is mainly regulated by arginine vasopressin, that is AVP, or antidiuretic hormone. The stimulus is increase in blood osmolarity. Now this stimulates the osmoreceptors in the hypothalamus to trigger release of ADH. Now the ADH release will be activating the AVP, arginine vasopressin B2 receptors in the principal cells in the collecting duct, which will lead to insertion of water channels in the tubular luminal membrane. Now this will lead to increase in water absorption, which will prevent further osmolarity increase. Now this slide shows the osmotic composition of plasma and various ions composition. Plasma osmolality is about 275 to 290 milliosmol per kilogram. Since sodium is the major ECF solute, its concentration determines the effective plasma osmolality. In this slide, we are looking at how changes in ECF osmolality affects the hypothalamic osmoreceptors. In condition of hypertonicity, the water will come out of the cell and cells will shrink and will stimulate the release of AVP. Whereas during hypotonicity, the water will enter the cells and make them rigid and will result in decreased AVP secretion. This slide is showing the principal cells in the late BCT collecting duct and how ADH AVP will act on V2 receptors and insert the Aquaporin 2 water channels in the luminal side of the tubule. This will help in the water reabsorption. This slide is summarizing the role of EDH in the late filtrate processing in the nephron. As we already seen, the trigger is the increase in plasma osmolality, which releases the antidiuretic hormone or ADH from the posterior pituitary gland, which regulates the water absorption by inserting the luminal water channels, that is aquaporins 2 in the principal cells. Let's also look at some of the non-osmotic factors that regulate ABP secretion. Effective circulating volume, which acts via baroreceptor in the carotid sinus, but mind you, this is less sensitive than osmoreceptors. The other cause is nausea, pain, stress, hypoglycemia, and pregnancy. Atrial natriuretic peptide is released following atrial stretch in vascular bed. It acts through cyclic GMP and inhibits the renin secretion and formation of angiotensin II, which leads to decrease in vasoconstriction and aldosterone secretion. Therefore, it tries to decrease the ECF volume. In hypovolemia, ANP secretion is suppressed. Now, this slide summarizes the regulation of water balance. When there is excessive water loss, there is increase in plasma osmolality. Now, this will stimulate osmoreceptors and ADH secretion, which will increase thirst, and this will lead to increased water intake and increased water retention, which will restore the volume and ionic composition of the ECF. On the other hand, when there is water excess, this will lead to decrease in osmolality, which will stop ADH secretion and stimulation of thirst. This will decrease low water intake and water retention. The increased volume leads to decrease in ADH secretion and renin secretion, but increase in ANP stimulation, leading to increased water excretion from kidneys, leading to restoration of volume. Now let's look at the sodium balance. As we know that most of the sodium is extracellular, which is a reflection of sodium content, and this is due to sodium potassium pump, which pumps 3 sodium outside and 2 potassium inside cell. Let's look at two important facts. When we see there is change in sodium concentration in the plasma, this is usually due to disturbed water homeostasis. On the other hand, when there is changes in the sodium body content, they will manifest as ECF volume contraction, hypovolemia, or expansion, which will lead to edema usually, and this implies sodium imbalance. You can remember that where the sodium goes, the water follows, and ECF volume is a reflection of total body sodium content. Therefore, if the sodium body content changes, ECF volume will change. Normally, volume regulatory mechanism ensures that sodium loss is equal to sodium gain. If there is sodium excess, it will lead to volume expansion, which will eventually lead to edema. Similarly, if there is sodium deficit, it will lead to hypovolemia. Let's look at the sodium intake sources. A typical individual eating a typical Western diet consumes approximately 9 to 10 grams of sodium chloride. The American Heart Association recommends no more than 2.3 grams a day for most adults. So the more the sodium in the diet, it can lead to ECF volume expansion, which will lead to high blood pressure unless the body excretes it out. This means that eating more sodium will lead to ECF volume expansion, which should enhance renal sodium excretion to maintain balance. I wish to point out here that as the stress is linked to cortisol hormone release, it is also seen that it can induce aldosterone secretion, which will burden the system with sodium and then contribute to hypertension. You can go through this research paper. I have given the link in this slide. Let's look at the sodium excretion. The regulation of sodium excretion will eventually determine sodium balance. A sodium deficit or excess is manifested as a decreased or increased effective circulation volume, respectively. Changes in effective circulating volume tend to lead to parallel changes in GFR. However, kidney tubular sodium reabsorption is the main regulatory mechanism and not GFR. Normally, almost two-thirds of the filtered sodium is reabsorbed in the proximal convoluted tubule. Of around 25 to 30% is reabsorbed in the thick ascending limb of loop of Henle using sodium potassium to chloride co-transporter, which is a active process. Distal convoluted tubule reabsorption is about 5% managed by sodium chloride co-transporter. And finally, sodium reabsorption occurs in cortical and medullary collecting duct via aldosterone. Aldosterone from the adrenal gland regulates the final amount of sodium reabsorbed. As you can see, the trigger will be a decrease in sodium, hyponatremia, or increase in potassium in blood, which will trigger the release of aldosterone. And the result will be both sodium reabsorption and potassium secretion increases. Let's look at the disorder of water metabolism. Hypovolemia. So by definition, true volume depletion is a combined state of salt and water loss exceeding intake. As stated above, the body needs to restore sodium and also water. Let's look at the renal causes of hypovolemia. Conditions which leads to both sodium and water loss are diuretics. Pharmacological diuretics usually inhibit sodium reabsorption in the nephron, leading to solute diuresis. So water will be lost along with the sodium. Next is the osmotic diuresis. Poorly controlled diabetes mellitus will leave the excess glucose in the tubular filtrate and will lead to water loss. Mannitol is a sugar alcohol that decreases the water and sodium reabsorption in the renal tubule and has been used for the reduction of intracranial pressure or cerebral edema. Next is the nephropathies, renal nephropathies, which will lead to salt wasting. That is the defects in the renal tubule, which will have problem in maintaining the salt and water. Then there is the hypoaldosteronism. Deficiency of aldosterone will ultimately lead to salt wasting, and that should have lead to salt wasting that can be reabsorbed. Now next is the renal water loss. For example, this is due to diabetes insipidus, which can be central or nephrogenic, where you will see the deficiency of ADH. In central diabetic insipidus, there is lack of ADH, and in nephrogenic diabetic insipidus, the kidney do not respond to ADH. Let's look at the extrarenal causes. Now we have fluid loss from GIT. Approximately 9 liters of fluids enter GIT, 2 liters of injection and approximately 7 liters of secretion. 98% is reabsorbed, and the fecal fluid loss is around 100 to 200 ml per day. Gastric secretions have low pH. Excessive vomiting will lead to metabolic alkalosis. Now intestinal secretions are alkaline. Excessive diarrhea will lead to metabolic acidosis. Coming to the skin and respiratory water loss, approximately 500 per ml per day. Febrile illness, excessive exercise, exposure to heat, sweating. Next is the severe hemorrhage. Next is after that we have fluid sequestration in third space, not part of ECF, ICF. These are the GIT obstruction, bowel lumen, severe burn, subcutaneous space, peritonitis, peritoneal cavity. Let's review mechanisms following hypovolemia. Following hypovolemia, hypotension sets in, which leads to decreased cardiac output. This will lead to stimulation of baroreceptors. These receptors are located in the carotid sinus and aortic arch. They respond to changes in the intravascular volume. This will stimulate the renin-angiotensin system and sympathetic nervous system. This will lead to cardiac and renal loss, renal response. The main goal of this mechanism is to maintain mean arterial pressure and cerebral and coronary perfusion. Under the cardiac response, there will be vasoconstriction, and under renal response, there will be a decrease in the GFR and also promoting sodium reabsorption. Neural control of renal blood flow. Sympathetic activity plays a central role in the control of renal blood flow. The sympathetic drive also increases during various situations like uh, standing or erect posture, during exercise, in conditions of pain, cold, and causing vasoconstriction. And this drive decreases during relaxed states, for example, lying down posture, warm conditions, and therefore it will cause vasodilatation. Increased sympathetic tone increases increased sympathetic. Let's look at the renin-angiotensin system, RAS. Now, it is stimulated by the hypovolemia, that is due to various stimuli, for example, reduced ECF volume due to hyponatremia, that is sodium depletion, hemorrhage, dehydration, heart failure, cirrhosis, sympathetic stimulation, reduced blood pressure, beta-adrenergic stimulation, that is the sympathetic stimulation already mentioned. Renin is a protease enzyme which converts inactive angiotensinogen into angiotensin 1, which is also inactive. This is acted upon by angiotensin converting enzyme, which converts it into angiotensin 2. This angiotensin 2 stimulates aldosterone secretion. Angiotensin 2 is also a vasoconstrictor and causes vasoconstriction, leading to increase in blood pressure. Angiotensin has also many other effects. It causes vasoconstriction in blood vessels, leading to aldosterone secretion, and on brain leads to thrust stimulation and release of ADH, which acts on kidney to reabsorb water, and sodium in the PCT. All these mechanisms tends to restore ECF and volume or blood pressure. It is time to look at some of the clinical correlates. ACE inhibitors like enalapril, lisinopril, captopril are used in the treatment of hypertension. ACE inhibitor decreases angiotensin 2 generation, leading to decrease in its volume and solute expansion effects. Now this slide reviews the action of aldosterone, and this slide reviews the action of ADH. And this slide will review the mechanism of ADH actions. To review the fluid movement between interstitial fluid and plasma, iron solutes and water move freely between the plasma and the interstitial fluid, except proteins, which will generate oncotic pressure in the blood vessels. At the arterial end, hydrostatic pressure is greater than the oncotic pressure, and vice versa at venous end. Edema. Edema is the accumulation of fluid in the interstitial compartment. It is usually of two types, local and general, when the edema is present throughout the body. There are mainly four causes of edema. First, there is decreased colloidal osmotic pressure, and it will lead to general edema, and usually mostly due to liver disorder. Next is the increased hydrostatic pressure. Again, it will be of general type, and this is mostly due to hypertension. Third is the increased capillary permeability, and this will be usually local edema and mostly due to injury, and different type of injury which can happen locally. And third will be the lymphatic obstruction. Again, it will be local in nature because of the removal of lymph nodes during surgery, as an example. Let's look at some of the sodium disorders. First, talk about the normal sodium plasma concentration, which is around 136 to 145 milliequivalent per liter. Plasma osmolality is given by this equation, which is twice the sodium plus BUN, that is blood urea nitrogen divided by 2.8 and glucose divided by 18 in milligram per deciliter. Hypernatremia, that is excess of sodium in the plasma. This is a small question here, so you can think of what effect would this increase in sodium concentration have on the cells that are bathed in the interstitial fluid if there is hypernatremia. You can think of this question. Yes, the answer is correct. The B, the cell shrinks. Now, causes and symptoms of hypernatremia. The sodium plasma concentration more than 145 milliequivalent per liter. So the external causes are decreased fluid intake. In cool environment, at least the intake of 700 per ml per day should be maintained. Increased skin loss due to profuse sweating. Renal causes, osmotic diuresis. Decreased ADH effect, central diabetes insipidus, for example, tumor, sarcoidosis, trauma. Nephrogenic diabetes insipidus, that is the renal disease, hypercalcemia, hypokalemia, lithium ingestion, urinary tract obstruction. Symptoms: non-specific signs, confusion of lethargy, and in severe cases, seizures and death, that is the neuron shrinks. Therapy of hypernatremia. Free water may be administered orally, which is the preferred route, or intravenously as a 5% dextrose solution. Vasopressin can be given as well. Types of hyponatremia. The sodium plasma concentration is less than 135 milliequivalent per liter. There is usually a misconception. This is a problem of too much water and not too little sodium. There are different types. There is the pseudo hyponatremia. This is a laboratory artifact that occurs in the setting of extreme hyperlipidemia or hyperproteinemia. This is seen usually when sodium is measured with the flame photometry and not with an ion selective electrode. So this is not seen in these days when we usually measure the sodium using ion selective electrode. Next is the hypertonic hyponatremia, which results from shift of water from ICF to ECF, which is caused by the presence of osmotic active particles, example glucose in the ECF space. Now the serum sodium concentration is reduced, but the osmolality of the ECF is normal or even above normal. With every 100 milligram increase in glucose above 100 milligram per deciliter causes a drop of 1.6 millimole per liter in sodium level usually. True hyponatremia. Hypotonic hyponatremia is clinically significant when the serum sodium concentration is less than 125 millimole per liter and the serum osmolality is less than 250 milliosmol per kilogram. Here we are seeing the various causes of hyponatremia. The main etiology is decreased renal water excretion due to various causes. Now, there can be decreased GFR, which can be due to decreased renal perfusion pressure in diseases like congestive heart failure. Next, it can be due to increased proximal tubular reabsorption due to various causes, or it may be due to various causes of syndrome of inappropriate ADH secretion, which is actually increased ADH secretion due to one of the underlying causes like any tumor, CNS diseases, pulmonary disease, for example. The mechanism is believed to be the so-called J receptors stimulation in the pulmonary circulation, or due to drug-induced SIADH, for example, this is chloropropamide or clofibrate. Let's see some of the therapy of hyponatremia. So number one, fluid restriction, that is restriction to the free water intake to approximately 700 ml per day. Diuretics therapy, inhibition of water reabsorption using, for example, diuretics like furosemide. Hypertonic infusion of 3% sodium chloride rapidly raises the tonicity of ECF. The amount of sodium needed to raise the serum sodium is calculated with the following equation. Normal serum sodium minus current serum sodium into total body water, or normal serum sodium minus current serum sodium into 0.6 into body weight. Potassium homeostasis. Let's see potassium homeostasis. The normal potassium plasma concentration is around 3.5 to 5.1 milliequivalent per liter. Potassium plays a key role in maintaining resting membrane potential, and therefore a major role in nerve impulse conduction, muscle contraction, and maintenance of normal cardiac rhythm. As hydrogen ion moves into and out of the cell in the body, there is a corresponding movement of potassium in the opposite direction. In acidosis, potassium comes out of the cell, lead to hyperkalemia and vice versa. Some of the clinical features of hyperkalemia are cardiac arrhythmias at more than 6 millimole per liter, neuromuscular disorder. Hyperkalemia alters muscular function, neuromuscular transmission leading to severe weakness and paralysis. Let's look at the causes of hyperkalemia. This is divided into extrarenal and renal causes. Under extrarenal causes, number 1, acidosis. As I mentioned earlier, acidosis will lead to increase in hydrogen ion concentration. Therefore, hydrogen ion move into the cells in the body with a corresponding movement of potassium in the opposite direction, leading to hyperkalemia. Number 2 is insulin deficiency. Now, insulin shifts potassium into cells by stimulating the activity of sodium hydrogen antipode on cell membrane, promoting the entry of sodium into cells. Now, this will lead to the activation of sodium potassium ATPase, causing an electrogenic influx of potassium. Intravenous insulin leads to a dose-dependent decline in the serum potassium levels. You can go through this research paper which discusses the role of insulin for the treatment of hyperkalemia. I have given this link. Next is hyperosmolality. Acute increase in ECF osmotic activity may produce a transcellular shift of potassium, resulting in hyperkalemia. Possible mechanisms are hyperosmolality will lead to loss of intracellular water, which will result in an increase intracellular potassium concentration. This will favor gradient for potassium to move out of cells. As water exits the cells, solvent drag will sweep potassium along. Under renal causes, severe renal failure with GFR less than 10 ml per minute will lead to hyperkalemia, as we are not removing the enough potassium from the body. Number 2 is various causes of aldosterone insufficiency. Number 1 is various causes are drug-induced aldosterone deficiency, like for example NSAIDs, which act to reduce renin secretion and may produce hyperkalemia through aldosterone deficiency. Aldosterone resistance in diseases like amyloidosis, obstructive nephropathy, lupus erythematosus. Now, acquired aldosterone deficiencies, for example in diabetic nephropathy, can lead to hyperkalemia. Therapy of hyperkalemia. Various things can be done to combat hyperkalemia. You don't have to go into details of it, but you should certainly know that there are things like calcium chloride, glucose and insulin, sodium bicarbonate, diuretics, cation exchange resins, dialysis, which can be done to mitigate the condition of hyperkalemia. Let's see causes of hypokalemia. Now, this can be again divided into extrarenal and renal causes. Under extrarenal causes, excessive vomiting. Now, this can lead to loss of acid in the vomit and will lead to metabolic alkalosis, leading to movement of potassium inside cells and hydrogen out of cell for compensation. Next is the insulin. This is usually due to potassium redistribution, insulin therapy, as discussed earlier. So, insulin can cause movement of potassium in the cells leading to hypokalemia. Similarly, epinephrine infusions. Acute hypokalemia can be produced by activation of beta 2 receptors. Acute alkalemia due to any other cause. Folic acid and vitamin B12 therapy for patients with megaloblastic anemia stimulates cell proliferation and produces acute hypokalemia as potassium is used in the cell synthesis. Now let's look at it under the renal causes. Excessive use of diuretics, primary hyperaldosteronism, primary adrenal adenoma, secondary hyperaldosteronism, that is the renal secreting tumors and congestive heart failure and cirrhosis. Potassium loss due to primary renal tubular disorder, that is the Bartter syndrome, defect in absorbing potassium ions in thin ascending loop of Henle. Now let's look at the chloride metabolism. Now metabolism of chloride usually run parallel with the sodium metabolism. Chloride metabolism is important constituent of caustic juice, which is rich in hydrogen chloride. Chloride ion takes part in acidic base balance by the mechanism of chloride shift. Plasma and CSF chloride levels. Normal level of plasma chloride ranges from 96 to 106 milliequivalent per liter. CSF chloride levels are higher than the plasma levels, that is 125 milliequivalent per liter. It is to compensate the low protein in CSF than in plasma. Intake and excretion of chloride. Major form of intake and excretion of chloride is sodium chloride. Dietary intake of salt is the main source and can vary from 5 to 10 gram per day. Renal excretion is also the same as 5 to 10 gram per day of the sodium chloride to maintain chloride balance. Hypochloremia. Common causes are prolonged severe vomiting or gastric fistula. As you can imagine, with severe vomiting, there is excessive loss of hydrogen chloride, that is HCl, which will lead to metabolic alkalosis. There is usually compensatory increase in plasma bicarbonate levels, leading to hypochloremic alkalosis in severe cases. Other causes are excessive prolonged sweating and Addison disease. Coming to treatment, we need to replenish the sodium chloride either orally or via intravenous route. Hyperchloremia. Common causes are dehydration, Cushing syndrome, severe pancreatic secretion loss or diarrhea with loss of bicarbonate, and compensatory chloride retention, renal tubular acidosis. Treatment of causes combined with sodium and potassium supplement and correction of acidosis. Some of the references for this lecture I will suggest are textbook of biochemistry for medical students by Vasudevan, D.M. Vasudevan, textbook of medical biochemistry by Dr. S.K. Gupta, Vichal Publishing Company, 2017, Harrison's Principle of Internal Medicine, Volume 1, 17th edition, Chapter 46, e-book available on Wolters Kluwer website. Now this is provided by our SRHU library. So you can go to this link I have given and use the username and password and you can search this book, textbook of medical biochemistry, 2nd edition, Rajendra Chawla, for this chapter and any other help on biochemistry. Please feel free to email me on my address neerajgupta@srhu.edu or WhatsApp me on 6261883112 for any queries you may have. I hope you have learned quite about water and electrolyte balance. Please let me know if you have any queries. Please follow the lockdown rule and keep safe. Thanks.